Okay, this is Chapter 7 of the Maternal Newborn ATI, Bleeding During Pregnancy. Vaginal bleeding during pregnancy is always abnormal and must be investigated to determine the cause. It can impair both the outcome of the pregnancy and the mother's life. Spontaneous abortion. Spontaneous abortion has occurred when a pregnancy ends as a result of a natural cause before 20 weeks of gestation, if a fetus weighs less than 500 grams. Types of abortion are clinically classified according to manifestations and whether the products of conception are partially or completely retained or expulsed. Types of abortion include threatened, inevitable, incomplete, complete, and missed. Risk factors is chromosomal abnormalities, maternal illness, advanced maternal age, premature cervical dilation, and maternal malnutrition. Expected findings are abdominal cramping, dilation of the cervix, fever. Lab tests are HGB and HCT if considerable blood loss. Clotting factors are monitored for disseminated intravascular coagulopathy. It's a complication with retained products of conception. WBC for suspected infection, and serum human chronic gonadotropin levels to confirm pregnancy. Diagnostic and therapeutic procedures. You're going to use an ultrasound to determine the presence of a viable or dead fetus or partial or complete products of conception within the uterine cavity. Examination of the cervix to observe whether it is opened or closed. Dilation and curettage, which is a DNC, to dilate and scrape the uterine wall to remove uterine contents for inevitable and incomplete abortions. Dilation and evacuation, which is a D&E, to dilate and evacuate uterine contents for inevitable or incomplete abortions. Prostaglandins and oxytocin to augment or induce uterine contractions and expulse the products of conception. Nursing care. Perform a pregnancy test, observe color and amount of bleeding, maintain client on bed rest, assist with termination of pregnancy, use the lay term miscarriage with clients because the medical term abortion can be misunderstood, provide referral for clients and partner for pregnancy loss support groups. The medications are analgesics and sedatives, prostaglandin and vaginal suppository, oxytocin, and Rh negative. Notify the provider of heavy, bright red vaginal bleeding, elevated temperature, or foul-smelling vaginal discharge. A small amount of discharge is normal for 1 to 2 weeks. Take prescribed antibiotics. Discuss grief and loss with a provider before attempting another pregnancy. Ectopic pregnancy is an abnormal implantation of a fertilized ovum outside of the uterine cavity, usually in the fallopian tube, which can result in a tubal rupture causing a fatal hemorrhage. Ectopic pregnancy is the second most frequent cause of bleeding in an early pregnancy and leading to a cause of infertility. Risk factors is any factor that compromises tubal patencies and contraceptive IUDs. Expected findings: unilateral stabbing pain and tenderness in the lower abdominal quadrant. Menses that is delayed, lighter than usual or irregular. Scant, dark red or brown vaginal spotting 6 to 8 weeks after last normal menses. Lab tests is serum levels for progesterone and HCG to help determine whether pregnancy has occurred and whether it is likely to be ectopic. Diagnostic and therapeutic procedures. Transvaginal ultrasound shows an empty uterus. Use caution if vaginal and bimanual examination are used. Rapid treatment is medical management if rupture has not occurred and tube preservation desired. Methotrexate inhibits cell division and embryo enlargement, dissolving the pregnancy. Salpingostomy is done to salvage the fallopian tube if not ruptured, and laparoscopic salpingectomy, which is removal of the tube, is performed when the tube has ruptured. Patient-centered care. The nursing care is replace fluids and maintain electrolyte balance, prepare the client for surgery and post-operative nursing care, obtain serum HCG, progesterone, liver, and renal function studies. If taking methotrexate, avoid vitamins containing folic acid to prevent a toxic response to the medication, and use protection against sun exposure. Gestational trophoblastic disease is the proliferation and degeneration of trophoblastic villi in the placenta that becomes swollen, fluid-filled, and takes on the appearance of grape-like clusters. The embryo fails to develop beyond a primitive state, and these structures are associated with choriocarcinoma, which is readily metastasizing malignancy. 2 types of molar growths are identified by chromosomal analysis. Complete mole. All genetic material is paternally derived. The ova has no genetic material, or the material is inactive. The complete mole contains no fetus, placenta, amniotic membranes, or fluid. There is no placenta to receive maternal blood. Hemorrhage into the uterine cavity occurs and vaginal bleeding results. Approximately 20% of complete moles progress towards a choriocarcinoma. A partial mole. Genetic material is derived both maternally and paternally. A normal ovum is fertilized by 2 sperm or 1 sperm in which meiosis or chromosome reduction and division did not occur. A partial mole often contains abnormal embryonic or fetal parts, an amniotic sac, and fetal blood, but congenital abnormalities are present. Approximately 6% of partial moles progress towards a choriocarcinoma. The risk factors are prior molar pregnancy, clients in early teenage years or older than 40. Expected findings: excessive vomiting due to elevated HCG levels, anemia from blood loss, and clinical findings of preeclampsia that occur prior to 24 weeks of gestation. The lab tests are serum level of HCG is persistently high compared with expected decline after weeks 10 to 12 of pregnancy. An ultrasound reveals a dense growth with characteristic vesicles but no fetus in utero. Suction curettage is done to aspirate and evacuate the mole. Following mole evacuation, the client should undergo a baseline pelvic exam and ultrasound scan of the abdomen. Placenta previa. Placenta previa occurs when the placenta abnormally implants in the lower segment of the uterus over the cervical OS instead of attaching to the fundus. The abnormal implantation results in bleeding during the 3rd trimester of pregnancy as the cervix begins to dilate and efface. Classified into 3 types dependent on the degree to which the cervical OS is covered by the placenta. Complete or total, the cervical OS is completely covered by the placental attachment. Incomplete or partial is the cervical OS is only partially covered by the placental attachment. Marginal is the placenta is attached in the lower uterine segment but does not reach the cervical OS. And low-lying is the exact relationship of the placenta to the internal OS has not been determined. Risk factors are previous placenta previa, uterine scarring, multiple gestations, and smoking. Expected finding: painless bright red vaginal bleeding during the 2nd or 3rd trimester, uterus is soft, fetus is in breech, oblique, or transverse position, vital signs within normal limits, and decreased urinary output. Lab tests are HCG, or HGB, HCT, CBC, coagulation, and the Kliefhalfer-Betke test. Assess for bleeding, leakage, or contractions. Assess fundal height. Refrain from performing vaginal exams. The client education is adhere to bed rest and do not insert anything into the vagina because it can worsen bleeding. Abruptio placentae is a premature separation of the placenta from the uterus, which can be partial or complete detachment. This separation occurs after 20 weeks of gestation, which is usually in the 3rd trimester. It has significant maternal and fetal morbidity and mortality and is leading cause of maternal death. Coagulation defects such as disseminated intravascular coagulopathy, which is DIC, is often associated with moderate to severe abruption. Risk factors: maternal hypertension, blunt external abdominal trauma, cocaine use, previous incidents of abruptio placentae, cigarette smoking, premature rupture of membranes, and multifetal pregnancies. Expected findings: sudden onset of intense localized uterine pain with dark red vaginal bleeding. Area of uterine tenderness can be localized or diffused over uterus and board-like. Lab tests are HGB and HCT, coagulation, Kliefhalfer-Betke test, cross and type match for possible blood transfusions. Palpate the uterus for tenderness and tone. Perform serial monitoring of the fundal height. Assess FHR pattern. Immediate birth is in the management. Provide emotional support for the client. Vasa previa is a condition when the fetal umbilical vessels implant into the fetal membranes rather than in the placenta. There are variations of vasoprevia. Villamentuous insertion of the cord, which is cord vessels begin in the branch at the membranes and then course to the placenta. Succinturiate, which insertion of the cord is the placenta has divided into 2 or more lobes and not one mass. Embauchador insertion of the cord is a marginal insertion, increased risk of fetal hemorrhage.